I've buried too many friends. I've stood at too many gravesides of men and women who came to me as patients, bright-eyed and hopeful, and left this world far too soon. After 50 years as a cardiologist, 40 years between Johns Hopkins in Baltimore and Hadassah Medical Center in Jerusalem, I've learned something that medical school never taught me in so many words. More testing is not the same thing as better care. After the age of 65, your body changes. Your arteries stiffen. Your kidneys slow down. Your brain processes information a bit more slowly. Your risk for certain diseases rises. That doesn't mean you should accept every test, every scan, every invasive procedure that a well-meaning doctor offers you. Sometimes the test itself causes harm. Sometimes it leads you down a path of unnecessary treatments. Sometimes it turns a healthy person into a patient for life. The rabbis of the Mishnah taught a principle that still guides me. They said, "First, do no harm." They understood that an intervention meant to help can also injure. They understood that wisdom is knowing when not to act. My grandfather Mordejái used to say in Warsaw, "A doctor who treats every symptom is like a man who chops down a tree every time a leaf falls." He was right. So today, I want to tell you 5 medical checkups I would never accept after the age of 65. Not because they're always wrong, but because they're often unnecessary, often misleading, and often the first step toward treatments that do more harm than good. The first checkup I would question is the routine coronary artery calcium, CAC scan, for primary prevention. This is a CT scan of the heart that measures calcium buildup in your coronary arteries. It's marketed as a way to see your heart disease risk before you have symptoms. And yes, calcium in the arteries is a marker of atherosclerosis. That's the buildup of plaque. But a CAC score is not a crystal ball. It tells you that plaque exists. It does not tell you whether that plaque is stable or dangerous. It does not tell you whether you are going to have a heart attack next year or in 10 years. I had a patient named Arthur from Brooklyn. He was 72. He was healthy, active, and had normal blood pressure. His doctor ordered a CAC scan because Arthur asked for the most advanced test. The scan came back with a score of 350. That's high. Arthur was terrified. He immediately started a statin drug, even though he had no symptoms. He developed muscle pain and fatigue. He became anxious. He stopped exercising because he was afraid his heart would fail. His quality of life collapsed. And here's the key point. Arthur never had a heart attack. Never. He lived another 11 years with that calcium score. Now, I'm not saying CAC scans are never useful. If you have symptoms like chest pain, or if you're making a very difficult decision about whether to start aggressive treatment, a CAC scan can sometimes help. But as a routine screening test in someone who feels well, it's often harmful. It turns uncertainty into fear. It leads to medications that you may not need. And it can distract you from the real drivers of heart disease: sleep, stress, diet, movement, and inflammation. If your doctor suggests a CAC scan after 65 and you're feeling well, ask these questions. What decision will this test change? If the score is high, what will we do differently than we're doing now? What are the risks of the radiation, the anxiety, and the treatments that may follow? If the answer is vague, walk away. The second checkup I would never accept is the routine full-body CT scan or whole-body MRI for cancer screening. These are scans of your entire body, chest, abdomen, pelvis, looking for tumors. They're marketed as early detection. And early detection can be good, but these scans are not like a mammogram or a colonoscopy, which are targeted tests with clear evidence of benefit. Full-body scans are fishing expeditions. Here's what happens. You get a scan. It finds something small, a lung nodule, a cyst in your kidney, a spot in your liver. In most people over 65, these findings are benign. They are normal parts of aging. But the scan doesn't know that, so you get more tests, more scans, more biopsies, more anxiety. You spend months chasing shadows, I had a patient named Margaret from Manchester. She was 67. She was healthy. She had no symptoms. She paid out of pocket for a whole-body MRI because she saw an advertisement online. The MRI found a tiny lesion in her liver. It was 1 centimeter. It was probably benign, but she was told she needed a biopsy. The biopsy was complicated by bleeding. She ended up in the hospital for 4 days. She developed an infection. She was on antibiotics. Her quality of life never fully recovered, and the lesion was benign. This is called overdiagnosis. It happens when a test finds something that would never have caused harm in your lifetime, but the medical system treats it as if it were dangerous. The rabbis of the Talmud understood this long ago. They said, "Do not create a danger in order to avoid a danger." In other words, don't trade one risk for another. After 65, your body is full of harmless abnormalities. If you have a symptom, unexplained weight loss, persistent pain, blood in your stool, a new lump, then targeted testing makes sense. But a full-body scan, just to be safe, is not safe. It's risky. The third checkup I would never accept is routine prostate-specific antigen, PSA, testing for prostate cancer screening in most men after 65. PSA is a blood test that can be elevated in prostate cancer, but also in benign prostate enlargement, infection, inflammation, and even after sexual activity. In younger men, PSA screening has a limited benefit and significant harms. In men over 65, the harms are even greater. Prostate cancer is often slow-growing. Many men over 65 will die with prostate cancer, not from it. If you screen aggressively, you will find many cancers that would never have caused symptoms in your lifetime. Then you get biopsies, which can cause infection and bleeding. Then you get treatments, surgery, radiation, which can cause impotence, incontinence, bowel problems, and a reduced quality of life. And for many of these cancers, the treatment doesn't extend life. I had a patient named Samuel from Toronto. He was 71. He had no symptoms. His doctor ordered a PSA test as part of a routine physical. His PSA was slightly elevated. He had a biopsy. The biopsy showed a low-grade prostate cancer. His urologist recommended surgery. Samuel went through the surgery. He was left incontinent. He was impotent. He was depressed. And 5 years later, he died of a heart attack, not prostate cancer. Now, this is not to say PSA testing is never appropriate. If you have symptoms like difficulty urinating, blood in your urine, or a strong family history with aggressive prostate cancer at a young age, then it may be reasonable to discuss it. But as a routine checkup for every man over 65, I would refuse it. Ask your doctor, what is my risk of dying from prostate cancer in the next 10 years? What are the risks of biopsy and treatment? What will we do if we find something low grade? If the answer is to treat automatically, that's a red flag. The fourth checkup I would never accept is routine annual stress testing or nuclear stress testing in people who feel well. Stress tests, where you walk on a treadmill or get medication that stresses your heart while they image it, are useful in certain situations. If you have chest pain, shortness of breath, or other symptoms suggestive of heart disease, a stress test can help. If you're considering major surgery and your heart risk is uncertain, it can help. But as a routine annual checkup in someone who feels well, stress testing is often useless and sometimes harmful. A normal stress test does not mean your heart is healthy. It means your heart performed adequately under a short period of stress. It doesn't predict plaque rupture, which is what causes most heart attacks. And an abnormal stress test in a person with no symptoms often leads to more invasive procedures, angiograms, stents, that may not improve outcomes. I had a patient named Helen from Dublin. She was 69. She felt fine. She exercised. Her blood pressure was controlled. Her cholesterol was slightly elevated. Her doctor ordered a nuclear stress test, just to be safe. The test showed a small area of reduced blood flow. She was sent for a coronary angiogram. That's a procedure where they thread a catheter into your coronary arteries and inject dye to see blockages. The angiogram showed a 70% blockage in one artery. She was told she needed a stent, a metal tube placed in the artery to keep it open. She had the stent. She developed a bleeding complication at the catheter site. She was in the hospital for 5 days. She had a reaction to the blood thinners they gave her. And here's the truth. The majority of blockages like that are stable. They don't cause heart attacks. The evidence shows that stents in stable coronary artery disease do not reduce the risk of heart attack or death compared to medications and lifestyle changes. But Helen had the procedure anyway. After 65, if you feel well and have no symptoms, a routine stress test is usually a trap. It creates findings that demand action, even when the action doesn't benefit you. Ask your doctor, am I having symptoms? If I have no symptoms, what exactly are we trying to find? If the test is abnormal, what will we do that we wouldn't do already? The fifth checkup I would never accept is routine annual screening for thyroid cancer with thyroid ultrasound in people with normal thyroid function. Thyroid nodules are incredibly common after the age of 65. Autopsy studies show that up to half of older adults have thyroid nodules. Most of these nodules are benign. Most will never cause harm. But if you do an ultrasound of the thyroid, you will find nodules. Then you get fine needle aspiration biopsies. Then you get surgeries. Then you get lifelong thyroid hormone replacement. I had a patient named Dorothy from Leeds. She was 76. She had no symptoms. Her thyroid blood tests were normal. She had a thyroid ultrasound as part of a comprehensive screening package offered by a private clinic. The ultrasound found 2 small nodules. A biopsy was done. The biopsy was indeterminate. That means it wasn't clearly benign, but it wasn't clearly cancer. She was recommended thyroid surgery. She had the surgery. The nodules were benign, but she now had to take thyroid medication every day for the rest of her life. She had a scar on her neck. She had complications from the anesthesia, and she felt worse, not better. Thyroid ultrasound is useful if you have a thyroid nodule you can feel, or if you have abnormal thyroid blood tests, or if you have symptoms like hoarseness or difficulty swallowing. But as a routine screening test in someone with normal thyroid function and no symptoms, it's a pathway to harm. Now, I want to be clear about something. I'm not saying that all testing is bad. I'm not saying you should never get scans. I'm not saying doctors are evil. Most doctors are good people doing their best in a system that rewards volume over value. But after 65, you need to be the gatekeeper of your own body. You need to ask harder questions. You need to understand the difference between a test that finds disease and a test that improves your life. The Talmud teaches that wisdom is not just knowledge. It's the ability to apply knowledge at the right time. A test done at the wrong time is not wisdom. It's just noise. So let me give you a simple rule of thumb. Before you accept any checkup or scan after 65, ask these 5 questions. First, what specific problem are we looking for? Not general screening. What specific disease with specific symptoms or risk factors? Second, what decision will this test change? If the result is positive, what will we do differently than we're doing now? Third, what are the risks of the test itself? Radiation, bleeding, infection, anxiety, false positives. Fourth, what are the risks of the treatments that may follow? Medications, biopsies, surgeries, lifelong side effects. Fifth, what is the evidence that this test will extend my life or improve my quality of life? Not, it might help. What does the research show? If your doctor can't answer these questions clearly, that's your answer. Walk away, get a second opinion, or simply say, no thank you. I also want to tell you what I would do instead after 65. These are the checkups that actually matter. First, A thorough history and physical exam, not a rushed visit, a real conversation. How are you sleeping? How is your stress? How is your digestion? How is your energy? How is your mood? What are you eating? How much are you moving? This is where real medicine happens. Second, blood pressure monitoring at home. Not just one reading in a doctor's office. Your blood pressure varies throughout the day. Home monitoring gives you a much clearer picture. Third, basic blood work focused on your actual risk factors. Blood sugar, lipids, kidney function, and inflammation markers if appropriate. Not every possible test. The tests that guide decisions. Fourth, targeted screening based on your personal history. If you have a family history of colon cancer, get a colonoscopy. If you have risk factors for osteoporosis, get a bone density test. If you have symptoms, get appropriate imaging, but targeted, not indiscriminate. Fifth, regular follow-up with a doctor who knows you as a person, not as a chart number. Continuity of care is one of the strongest predictors of good outcomes. A doctor who knows you over time can see patterns that no single scan can see. I had a patient named Rebecca from Liverpool. She was 72. She came to me after a series of unnecessary tests had left her anxious and over-medicated. She'd had a full-body scan that found a benign lung nodule. She'd had a stress test that was abnormal, but she had no symptoms. She'd had a PSA test that led to a biopsy. She was on 5 medications and felt terrible. We stopped the unnecessary testing. We focused on her sleep, her diet, her movement, her stress. We reduced her medications. Within 6 months, her blood pressure normalized, her blood sugar normalized, her energy returned, her anxiety disappeared. She told me, "I feel like I got my life back." That is the goal of medicine after 65. Not more tests, more life. My grandfather Mordejái used to say, "The wise person does not fear the unknown. The wise person knows when the unknown is not worth chasing." That wisdom has guided me through 50 years of practice. It has kept me alive. It has kept my patients alive. I've written down everything I've learned about senior medical care. What tests to accept, what tests to refuse, what questions to ask, and how to have these conversations with your doctor into a single practical guide. The link is in the description below. It's written in plain language. It's specific. It's based on both modern science and the wisdom of how human beings actually heal. But you don't need the guide to start. You can start tomorrow. The next time your doctor suggests a test, ask one simple question. What decision will this test change? If the answer is fuzzy, you already have your answer. Your body is not a machine to be scanned into submission. It's a garden to be tended. And after 65, tending means knowing when to act and when to let go. That wisdom may be the difference between a longer life and a better life.